It's sort of an uncommon manifestation of a common entity. So hopefully, okay. Can you see my screen?
Yes.
Okay. So patient is a known cirrhotic. So this is the older scan from a few months earlier. And I think the sagittal also shows the findings. Does anybody want to say anything about the pelvic findings?
Looks like a lot of collateral vessels, but also
Right.
closely affiliated with the bladder.
Right. So, and this is a female patient. She has had a hysterectomy and oophorectomy before. So, like you said, they're all collaterals in the bladder wall, around the bladder wall, and in that vesicouterine space where the uterus would have been. So, this was her a few months ago. And then more recently, she comes in with hematuria, like massive hematuria. And then this is the arterial phase. There's a Foley in the bladder, and then you see there is stuff around the Foley. And then there are these lobulated enhancing vessels. And I thought the portal venous phase was really impressive. So the kidneys and ureters are not yet excreting contrast, yet there is a large amount of contrast in the bladder.
Wow. I've never seen this. That's cool.
I know.
You see it in the stomach, like GI bleeding,
right,
gastric
right,
varices, but
right.
I wonder, it must be more difficult for them to get into the bladder wall.
It must be. So few things. So this was basically like a portosystemic shunting. And the reasons why we have to know this is these can be like unrecognized causes of encephalopathy. And for the IR guys, this is important because they need to know what approach they need to take in order to go ahead and embolize these. So just pulled up a few things about this entity. So we all know about portosystemic collaterals, but something we don't see is this portal to sort of splanchnic circulation in and around the bladder. So you can have varices. The usual ones we see are the gastroesophageal and the ectopic varices. And the shunts then can be intrahepatic, transhepatic, extrahepatic. So some of the rare ones in this category are these splenogonadal, mesenterico renal or mesenterico caval. I've definitely not seen any of the pulmonary shunting ones. So just something to remember. And they said this is much more common in patients who've had a hysterectomy before because the uterus is not there to divert some of the blood flow through the iliacs into the IVC. They end up pooling at the vaginal apex, forming these huge varices. So unusual manifestations when these patients can present with either vaginal bleeding or hematuria, but all attributable to a common cause we see every day from cirrhosis.
Nice. Roopa, going back to your slide, what is exactly the difference between a varix and a shunt in this setting?
So I think varix is like from one vessel to another directly, and shunts can be not vessel to vessel. They can be more like even like small masses, which we see like shunting in the liver type. That's what I understood, at least. I'll send you this article. Maybe you'll get more out of it. I did wonder about that too, but that's kind of what I got. Is one is more of a direct vascular communication. The other is more into a space, perhaps.
Got it. Okay.
Yeah.
And these ones in the bladder wall, though, are probably varices in the bladder wall.
They are varices from the splanchnic circulation, basically.
Cool.
So then they went ahead and they did lipiodol injection into all of these, and it took a lot of injection to control the bleeding. But right now the patient is hemodynamically stable. So it was just an unusual case. Had never seen hematuria present from cirrhosis with. And one of the other reasons they say why these types of collaterals preferentially form is maybe they've had banding upstairs, so there's not a pathway open up there to form the usual collaterals we would expect. So then they start going into these unusual places.
Cool.
Yeah, that's all I have. Thank you.
Thanks. Ben, you want to go?
Sure, I'd love to present. One moment. This is a case that has 3 different imaging studies. One of them is approximately 7 years ago. One of them is approximately 2 years ago, and one of the last 2 screens down here are more recent. So this was a patient who had a syndrome. But I draw your attention to the fact that the adrenal gland on the left is missing. Then there is this focus in the pancreas, and there are 2 foci in the kidney, one here and one back here. He has other finding, different imaging modality that I don't have on the images that I have displayed. But do you guys know what entity I'm trying to show?
Okay, wait, let's think about it. People speak up, chat in. You said the left adrenal is missing. I see like a nodule in the right adrenal also.
Yes, there's one. They actually took this one out as well later on. And we know what it is because we have the pathology from that surgery.
Okay, wait. And then there's renal masses.
Renal masses.
Pancreatic masses.
Pancreatic masses, yes.
So renal and pancreas make me think of von Hippel-Lindau.
That is what this is, yes.
Oh, yeah, that's what Roopa said too. And then in the adrenal, does VHL give you paragangliomas or leptios?
I think they get neuroendocrine tumors in the adrenal gland. They get hemangioblastomas in the CNS. I don't have the CNS imaging up, but this patient has that as well. But this was an interesting case with a bunch of the findings, so I wanted to just show it really quickly.
Wait, quick question. For adrenal gland, they get pheos, right? Not.
Yes, pheochromocytomas, correct. And they were resected and they were pathologically proven pheochromocytomas both on the left and on the right. Yes. He's actually currently being followed up for these RCCs in his kidney.
Yeah, so one point about von Hippel-Lindau related RCCs, they tend to both get lots of renal cysts as well as cystic RCCs. And then their RCCs are more indolent than a regular RCC. And they want to do nephron sparing surgery to kind of make sure, because they're going to get more and more lesions over time. So they tend to not resect these until they get about 3 centimeters. And if it's a cystic mass, they'll look at the solid portion and wait for the solid portion to get 3 centimeters big before they start doing like partial nephrectomies.
Thank you for adding that. Yeah, so this was just a cute case I wanted to share. That's all I have.
Cool. Welcome, Bhavik. I see Bhavik has also joined us today. I'm going to share my screen. Okay. So this first case is this cystic lesion, and I want you guys to chat in. I'll try to see if I can see the chat. Okay. So there's a cystic lesion here. It looks a little bit complex. It has some internal structure to it. And it looked like this on the axial haste. Pre-contrast, it was pretty bright. It had a lot of hemorrhage within it. Post-contrast was pretty confusing, so I'll just go to the subtractions. And this patient was having hematuria, and we thought that this was basically some misregistration. We didn't think that there was true nodularity in it. And Bhavik says hi in the chat. And then 6 months later, they came back, and this is what the cystic lesion looked like. And we can see that maybe there's some nodular components centrally here. And I will just cut to the subs. I think this was the one. And we were concerned that there was some nodular components here. So any thoughts about what this could be? Ben is saying cystic RCC. Excellent. That's the main thing. We would say basically this is a Bosniak 4 using the new 2019 Bosniak classification using MR. It's got a true nodular enhancing nodule. And so we said this is concerning for a cystic RCC. And those tend to do better than solid ones, even if it's a Bosniak 4. But the final pathology was not a cystic RCC. So any other guesses? I don't expect, I mean, this was a post-path diagnosis. Okay. Divya is asking for clear cell. So that would be a good type of RCC, which can be cystic, but papillary can be too. But in the end, this was a collecting duct carcinoma. So just a couple of points about collecting duct carcinomas. They used to be called Bellini duct carcinomas because they come from the medullary cells and the Bellini cells. They're very aggressive. It's usually it's a rare type of carcinoma. They tend to be infiltrative or large, but they can also be cystic. And even though ours looked pretty, pretty contained here, like it just to me looked like, oh, it's just a small little nodule. It was actually, there were tumor cells along this entire wall, and it was actually invading the perinephric fat as well as the renal sinus. So just a rare type of tumor, collecting duct carcinoma. They're usually infiltrative, but they can be cystic, and they tend to have a bad prognosis. So if you're reading a follow-up exam, you want to look really carefully for recurrence. Okay, my next case, this is just a cute one, recent one, and this is for the residents out there. So what do you think about these lesions? This was an upper GI study, a double contrast. Here we are in the duodenal sweep here. What do you think about these guys? Yes, Bram says duodenal diverticula. Good. So this was just a cute example of duodenal tics. These are very common. So of all the small bowel, the duodenum has the most tics, and about 22% of patients have duodenal tics. The most common area is this area over here, this periampullary area. And does anyone know what the syndrome is called when you have CBD obstruction due to a duodenal diverticulum? I feel like Roopa is going to know this.
I have a case of it, but I don't know the name. Oh, I know. Bouvray.
No, so Bouvray is when you get gastric outlet obstruction from a gallstone that has eroded from the gallbladder.
Oh, yeah.
And that has a high mortality. This is called Lamel syndrome. So basically these periampullary diverticula are usually incidental. 90% of them will be completely asymptomatic. However, in some cases, you can get a Bezoar in here. You can actually get the common bile duct inserting on it, which can be hard if you're doing an ERCP to get into the common bile duct. And if it gets a lot of like debris, it can actually impact and cause common bile duct obstruction, and that's called Lamel syndrome. So anyway, this was just a cute case of a couple of tics. This is an interesting case. So this patient came in, they were having some vaginal discharge, and this is what their sagittal uterus looked like. So we saw some cystic spaces, maybe some nodular areas. I'll show you the axial. You can see that there's like cystic spaces, but it also looked like there was some nodular components in it. So we weren't sure, is this just Nabothian cysts and a tunnel cluster, or is this really a something to be concerned about? I'll show you the pre and post. Okay, well, I don't know. But this is the it looked a little bright. This is the post, and I'll show you some subtraction images. Okay. So any thoughts? Do you think that this is just, it looked like there was some enhancement of those nodules. So are you favoring a tunnel cluster? Are you favoring something malignant? Go back to my T2. Rupa's asking if there's watery discharge. It wasn't that watery, but there was some vaginal discharge. So Roopa, you were asking about watery discharge. So what are you thinking about?
Gitanjali, I and somebody else said adenoma malignum.
Yeah, exactly. So anyway, this was resected and it came back lobular endocervical glandular hyperplasia, which was something I didn't know about. It's called LEGH. And this is a benign condition, but 30% of these patients it's a precursor to adenocarcinoma. So for cervical cancer, about 85% is going to be squamous, and the other 15% are going to be adeno. And hold on one second. So LEGH is associated with minimal deviation carcinoma, which is the new term for adenoma malignum, and also this gastric type mucinous adenocarcinoma. So basically, this is all on a spectrum, this adenoma malignum, this mucinous adenocarcinoma, and this LEGH. And so if you see something that looks like this flower type appearance, you should start bringing up that this could be either adenoma malignum or on the spectrum. Or, and this is a paper from Japan, they talked about these raspberry lesions, which are kind of almost like the microcystic lesion in the cervix. These have even a higher rate of being malignant and turning into this medial deviation carcinoma. So our patient ended up getting a hysterectomy. This was lobular endocervical glandular hyperplasia. So it's not just Nabothian cysts. It did look a little bit different than just a tunnel cluster. And this was in 30% of cases, this LEGH is a precursor to adenocarcinoma. So you still, it's still good that we resected this. And just as a companion case, here's a patient that's just a more classic kind of tunnel cluster where you've got a bunch of more simple Nabothian cysts. This was also resected and turned out to just be Nabothian cysts. So there can be a overlapping spectrum, but when it looks more simple like this, it's usually statistically even Nabothian cysts much more common. And then this
Aarti, do you know prognostically how they do compared to squamous cells if they end up being adenos?
Yeah, so I'm trying to think, because I was reading about these mucinous adenocarcinomas, and they're very much like gastric mucinous adenocarcinomas. And so when it truly is a mucinous adenocarcinoma, they do worse. But I don't know how much worse they do.
Okay.
But I was reading that like squamous cell is now so much less common because of the vaccine and, it's related to HPV. So we're getting less squamous cell, but there's a small kind of slowly rising incidence of adenocarcinoma because these are not protected by the HPV vaccine. And then this is the final case. It's just a companion case to one that Manjul showed a couple of weeks ago. And we can see that there is a process going on from the kidney into the renal vein, into the IVC, and extending into the suprahepatic IVC. I'll show you on another sequence. So even though it looks like a lot of it is in the IVC and in the renal vein, and there isn't like as big of a mass here, there is a more infiltrative mass here with a lot of these vessels. And so this was an RCC that was kind of not a round, big, huge RCC, but it is an infiltrative RCC. And then a lot of it was going into the renal vein, into the IVC. They were able to intraoperatively, they were able to go here. So you always want to report where the highest level of your tumor thrombus is. So they know, and in this case, they could see that it was going basically into the suprahepatic IVC. It actually went even a little bit further by the time they did the surgery. And they were able to make a hole in the diaphragm and clamp off the suprahepatic IVC here, peel out this tumor and resect about 70% of the IVC, and then repair the IVC with a patch. So anyway, this was just a kind of cool case where it wasn't as big of a tumor in the kidney, kind of like Manjal's case, but huge tumor thrombus in the IVC. Okay, that's it for me. Nellie said she was going to be here like 15 minutes late. I don't think she's here yet. Does anyone else have cases? Such a quiet group today. I think we're all still recovering from SAR. Should we wait for Nellie for a couple minutes, or just call it early today? Can you guys hear me?
Yes.
Okay. Sorry, Victoria.
I have work to get back to, so I'm gonna go.
Okay, yeah, Victoria's moving actually today to Boston, and Nellie said she was going to be a little late, so I think we're just going to call it early today. Thanks everyone for coming, and welcome Bhavik, and bring your cases next time. I will see you guys later.
Nice cases. Thanks, Aarti.
Bye.
Thanks, Aarti.